Hello everyone, this is Dr. Milas again. Let us now discuss about ADPKD. Okay, that is autosomal dominant polycystic kidney disease. As we all know, it is a common inherited disorder which is characterized by the formation of numerous fluid-filled cysts in the kidneys, which causes the enlargement of kidney and progressive impairment of the function of the kidneys, right? And can also affect other organs like liver, pancreas, cardiovascular system, right? Now, inheritance, if we see, it follows autosomal dominant as the name suggests. Okay, so that means that 50% chance of the getting the mutation from the parents. So there are two types of mutations happening here: PKD1, PKD2. PKD1 is most common, 85%. It is because of polycystin 1 gene, which is present on the chromosome number 16. Okay, so it progresses faster and it is associated with more severe disease and early onset of symptoms. While PKD2, 15% cases because of the chromosome number 4, which encodes polycystin 2. It is a milder disease and slower progression and later onset of end-stage renal disease. Now, coming to the onset of disease, as I said, PKD1 will have early presentation, that is around 30s, and PKD2 around 40s and 50s. Right. Kidney pathology, as I said, because of the cysts are formed in the renal tubular epithelial cells, right? This will enlarge and which compress the surrounding kidney tissue, that is the problem, and which will reduce the renal function. So tubular obstruction, which leads to development of the cyst, right, and surrounding the compression on the surrounding parenchyma, which undergoes fibrosis and ischemia, and gradual loss of nephrosis will be there. Clinical features: renal enlargement will be there, so mass will be there, abdominal mass will see, and pain patient will be complaining of, right? Renal cyst, often they are bilateral and thousands in the advanced disease, right? And progressive renal disease, patient will land up 50% in the cases of PKD1 will land up in ESRD at the age of 60 to 70, right? Next is renal symptoms: hypertension, 80% patient will be having that, and this is the most common or the first clinical sign. Due to this is because of the cystic compression of the renal vasculature, right? And there is activation of RAS. Next is flank pain. Okay, chronic will be there, acute if there is a hemorrhage, cyst hemorrhage or infection. Next is hematuria. Okay, external manifestation: liver cyst is most commonly seen. Okay, is mostly asymptomatic but can also present with pain and hepatomegaly, right? Next is pancreatic cyst, which is rare but can occur. Intracranial aneurysms, like 5 to 10% cases will have that. Okay, particularly in the patients who's having the family history of aneurysms and the risk of rupture that will lead to subarachnoid hemorrhage. Mitral valve prolapse, which is the most common entity seen in the cardiovascular system. Colonic diverticulosis and hernias. Okay, cardiovascular complications like hypertension, left ventricular hypertrophy because of chronic hypertension, aortic root dilatation, dissection. Okay, it's seen in some patient, but it increase the morbidity. Intracranial aneurysm, as I said, 5 to 10% patient will be having. Okay, these factors are family history and smoking and chronic severe hypertension. So screening has to be done, especially for those patients who are having family history and the risk factors like smoking and chronic uncontrolled hypertension. So diagnosis can be done with ultrasound. Okay, it is cost effective, most commonly used, right, to detect the cyst in the kidneys and the liver. Or CT MRI we can do, which is more sensitive, especially when the ultrasound is equivocal. Genetic testing to confirm the diagnosis. Now, if you see the diagnostic criteria, ultrasound basis, so based on the age and the number of cysts. So age 15 to 29 years old, at least 2 cysts has to be there in either unilateral or bilateral, right? 30 to 59, 2 cysts in each kidney. Bilaterally there should be 2, that means 4, 2 here right and 2 left. In more than 60, 4 cysts in bilateral kidneys, right? Coming to the complications: CKD, that is end stage renal disease, hypertension and the other complications related to the hypertension, chronic hypertension, then cystic infection and nephrolithiasis, uric acid and calcium oxalate stones will be found, right? Risk factor for rapid progression, as I said, PKD1 mutation, male sex, hypertension before age of 35, gross hematuria if the patient is having, that means there is a advanced disease. Okay, large kidney size at the early age and proteinuria. Okay, now coming to the management, so blood pressure control has to be done, and first line therapy is ACE inhibitors and ARBs. Okay, other than that we can use tolvaptan, okay, which is a vasopressin 2 receptor antagonist, okay, which is approved and it is seen that using tolvaptan, the size of the growth of the cyst will be delayed, means slow progression of the disease will be there. For pain management, you can use non-opioid analgesics, okay, and surgical interventions like cyst aspiration, laparoscopic cyst penetration, etc. Cyst infection, you have to use antibiotics, and but antibiotics only those which penetrate the cyst, for example fluoroquinolones or even cotrimoxazole. But like our common antibiotics, penicillin, cephalosporins, are of no use because they are not able to penetrate the cyst. Nephrolithiasis management by increasing fluid intake, pain management, and surgical removal of the stones. Dialysis for patients who are landed into ESRD, and kidney transplantation are definitive treatment, and patients typically do well after the transplant. Okay, so monitoring has to be done, regular monitoring for the kidney functions like GFR, EGFR, serum creatinine and cyst size, blood pressure control, screening for aneurysm, especially those who are at high risk. Other than the lifestyle modification, low sodium diet, and maintain hydration until there is a ESRD or fluid overload. Until then, patient has to drink more and more water to avoid nephrolithiasis, avoid nephrotoxic drugs, exercise, right? So prognosis